Good afternoon, and welcome to the webinar entitled Integrating the Commission on Cancer Requirements into Your Community Health Needs Assessment. I'm Debbie Thompson, and I'm President and Founder of Strategy Solutions. And we're here today to talk a little bit about what's going on in the world of community health needs assessment, especially focused on those hospitals or health systems or organizations that are in fact accredited by the Commission on Cancer. And I found out that Strategy Solutions does quite a bit of work with hospitals and health systems on community health needs assessment and training leaders on thinking about how community health needs assessments fits into population health planning and thinking about how we evaluate the outcomes and impact of our work. And I actually found out about these requirements actually quite by accident from one of our clients who was, bringing on the 2015 requirements and talking about, well, how does this fit into the community health needs assessment? So we're going to talk about the requirements because I doubt many of you who are community health needs assessment coordinators or community health improvement facilitators in your hospital or health systems are spending time in the weeds reading the Commission on Cancer Guidelines. So we're going to talk a little bit about those guidelines that you may not be aware of. And I decided to do this webinar because I was afraid, and I did find somebody who was doing this. I was afraid that many of our hospitals out there might be doing double work, that they have two different needs assessment processes going on, one within their cancer program and one with the overall hospital. So the two of them can fit together very easily. It actually makes sense to do one process that meets all the requirements that can easily be done if you know how to do it. So I'm going to talk a little bit about identifying strategies to integrate the two processes so that your hospital or health system doesn't have to duplicate effort or waste resources. And then talk a little bit about the outcomes measurement and evaluation techniques to help you identify and report the impact of those efforts without getting into a lot of detail on that. If you're interested on outcomes and impact measurement and evaluation, we actually have separate webinars on those topics. We'd be happy to send you the recorded versions of those or do one for your organization. I also want to do a little commercial that if any of you who are listening to this webinar, either in the live version or
the conference has been muted.
I would be happy to do this webinar for a team at your hospital at a time that is mutually convenient for us. If you feel that this is a message that your organization needs to hear, we would schedule that and do that for you free of charge. So, take us up on the offer if you're interested. For those of you who may not be familiar with Strategy Solutions, we're a company with a mission to create healthy communities. And every client that we work with, our planning and evaluation process really asks 5 questions. Where are we now? Where do we want to be? How are we going to get there? Who's going to do what? And how are we doing? And when we work with clients, what we are really trying to do is help build the bridge from strategy to results, to really operationalize things. And when we work with a client, particularly when we're doing evaluations, we're assessing the gap between where you are and where you want to be. We'll sometimes fill the gaps immediately through best practice role modeling by teaching the organization how to do outcomes measurement or how to connect the dots, and then work on alignment so that everybody's on the same page and that you're really bought into and supporting an action plan moving forward with what you want to do. Now, the IRS, this is a reminder for most of you, I'm sure, the IRS CHNA guidelines. The letter of the law is we've got to conduct a needs assessment every 3 years, identify chronic disease conditions, identify assets and strengths, identify and connect with the needs of underrepresented populations, and evaluate the outcomes and impact annually with a 990 submission, and especially every 3 years when you replicate the study. The spirit of the law, of course, is a population-based planning and healthcare delivery system. and to manage the health of the population to achieve the triple aim. That's why the IRS put those guidelines in place. Now, I'm going to talk a little bit about the Commission on Cancer Guidelines, and I'm not going to go through these in great detail, so I'm not going to read the slides per se, but they're in here for you, and Kathy from my staff will send you these slides after the webinar so that you have the slides and the little newsletter article, which you may already have, that I wrote on what the webinar is about. But I want to talk about some of the highlights about the goals. The Cancer Committee is responsible for, with an organization that is accredited by the Commission, is responsible to establish, implement, monitor at least one clinical and one programmatic goal for every year for cancer care. The goal is evaluated at least twice annually, and that evaluation process has to be documented in the minutes. Okay? And what's interesting about that is the goals don't have to be completed every year, but a different set of goals needs to be established annually. So you can start a goal in year one, you can keep working on it in year two, but in year two you've got to come up with a new goal or goals. And you also have to be monitoring community outreach. The Commission on Cancer requires the establishment of a community outreach coordinator whose job it is to help identify barriers to access and also to identify disparities that play into barriers to access. And this is for cancer care. Now, most hospitals, well, actually, I think I have to say every hospital that we've ever done a community health needs assessment for, regardless of which part of the country it was in, ended up with cancer on its top 10 list. Whether it was cancer in total or one type of cancer, cancer is always there as a chronic disease. And it's going to stay as a chronic disease on our list, at least for the foreseeable future. So the outreach coordinators that are part of our cancer program can actually give us probably voluminous data for our community health needs assessment just based on what they see, okay? They have to, as part of the Commission on Cancer Outreach, document an activity summary that's presented to the Cancer Committee annually. We ought to take that activity summary and put it as part of the needs assessment because they have all kind of information. They're a wealth of information because of everything that they see. We also have to look at any type of prevention and early detection screening programs. They have to be monitored by the Cancer Committee to ensure that appropriate services are provided to patients in the community and that the scope of the service and the methods are also evaluated. And those same outreach activities, many hospitals are counting those as community benefit activities, but not necessarily. They may be counting the screening programs. I've seen many hospitals do their screening programs as part of their implementation strategies, but I haven't seen the connection with the data of the outreach coordinator really brought into the needs assessment process, or really connecting the dots to have the cancer program and the cancer committee be part of the needs assessment process on an ongoing basis. We're actually about to start a needs assessment where we're going to be doing that because we have a client that's accredited and is combining those processes. But from a compliance perspective, these are the things that the Cancer Committee has to evaluate on an ongoing basis. They also have to do public reporting of outcomes. Each year the Cancer Committee develops a report and makes it available to the public of one or more of these following outcomes. Now, most cancer programs are doing it on their own. I'm actually suggesting that the cancer program report be a subset of either an overall community benefit report or an overall implementation strategy evaluation report that is published to the community that talks not just about the cancer program, but talks about all of the interventions that the hospital or health system is doing in response to community needs, and what are the outcomes and impact of those programs. And we've also been encouraging our clients in recent years to take that document that is the evaluation document of the implementation strategies and include it as an attachment to the 990 that's submitted to the IRS. More on the Commission on Cancer Guidelines. They also, a phase-in this past year is the patient navigation process, which needs to be driven by a community needs assessment established to address healthcare disparities and barriers to access. So the needs assessment really needs to be looking at those items specifically so that the organization can address those needs. The requirements also say that resources to address identified barriers may be either on-site or by referral to community-based organizations. Okay? So we got to have that resource directory. That's one of the requirements in the overall community health needs assessment. Are we looking at that? So here's the compliance on that. Conduct a community needs assessment at least once during the 3-year cycle, so every 3 years. Establish patient navigation and identify resources to address barriers. The barriers to care are assessed every year, and the navigation process is evaluated, and then it's enhanced or modified. So here's the questions to ask yourself. How effectively are you assessing community needs and managing the health of the population at risk or with cancer? And here's really the questions that you should be asking yourself. Is your cancer committee conducting a separate community health needs assessment? Are you doing a separate activity just for cancer? Does the cancer program identify a separate list of resources available to address barriers? The overall community health needs assessment has to put together a resource directory or an inventory list or an asset map. We call them all those things interchangeably. But does the cancer program develop and maintain its own? Is the navigation and barrier elimination process reported only to the cancer committee? Or is that information shared with overall community benefit and counted as part of the community benefit and also part of your community health implementation strategies? Because I'll bet cancer is a high priority in your local service area. And then here's a really important question. Does your navigator use a paper system and or an Excel spreadsheet to keep track of their activities and outcomes? So here's some strategies to connect the dots, especially if the answer to any of those questions is yes. First of all, you want to envision your cancer program as a community health improvement strategy for the population at risk or experiencing cancer. That's the first thing. Really think about secondly, view the needs assessment for your cancer program as a key component of the overall needs assessment and design a combined methodology that meets both requirements. It's really not that hard, and I'm going to explain in a few minutes how to do it. Recognize that the outreach and barrier elimination process, as I've already said, should be counted as a community benefit, evaluated, and included as an intervention strategy. I have told countless hospitals that even those who have a minimalist approach to the IRS requirements, you're already doing this stuff. You should take credit for it. You should report it to the IRS. You should report it to the public. You should shout it from the rooftops and let everybody know the wonderful work that you're doing to really impact the care delivery and the quality of life for the person served. And then automate key metrics associated with the cancer program as part of the EMR. So your navigator's not keeping track of things on a tick sheet on their desk or in a spreadsheet. So I'm going to talk about these things, how to connect the dots in each one of these areas. I'm first going to talk about how do you envision the cancer program as a population management strategy. Well, first of all, you think about the healthcare evolution and where are we going in healthcare. We're moving from a volume-based first curve, and many of us in our daily lives in cancer programs are still in the fee-for-service world. We have kind of a siloed approach to the different aspects of cancer care, and that's okay. That's the way things are. We're moving toward a value-based second curve where, quality is going to make a difference in reimbursement, and hospitals and health systems are starting to take on more risk through accountable care organizations. But we're really moving toward the second curve of population health, where social determinants of health are now part of the key delivery system and part of the care management. So we're really thinking about that triple bottom line. But we don't really think about, I don't know if we have a map. I love this graphic. I actually adapted it from Colonnade Health because it really shows the kinds of programs that are done for healthy or slightly at-risk patients, for at-risk patients, for those with chronic or complex diseases. One of the first strategies I'm going to recommend to you is to sit down and really think about, what does this map look like for you? What is your health system doing within your cancer program across the continuum of care? And I would do a separate map for breast cancer, for colon cancer, for prostate cancer, for any of the cancers that are significant in your area. I would look at, what are the community benefit or outreach or screening programs that we're doing to what's typically the healthy population? What are those intervention strategies that we're doing toward the at-risk population? And what are we doing in our service lines on an inpatient and outpatient side to really provide care and to help people manage the complexities of receiving that care and making good choices for their quality of life? That's why the Commission on Cancer requires that navigation process to help move in that direction. But it would be highly illustrative for your cancer program if you don't have a document like this that shows all the services kind of all in one place. So you can look at what's the patient experience from the front door the moment they're diagnosed as they walk through the various component parts of the process. And then if they're receiving chemotherapy or radiation, or they're having surgery, and how are all of those things managed, and what are all of those component parts that become part of that experience? This mapping it out could be really helpful for you. It will also help you look at how do we look at the outcomes and impacts over time. The second thing you want to do is view the needs assessment for your cancer program as a key component of the overall strategy, and design the methodology to ensure participation of one or more cancer committee members. Gather input from individuals within the cancer care continuum as well as those who are at risk. And I said earlier today when I was talking to one of my colleagues about this means that we have to have our methodology include specific focus groups or interviews with people who have various types of cancer. That's an easy modification to a needs assessment design if you're not already doing that. And some hospitals and health systems are already doing it. And then the other thing to do is to create one centralized resource directory that can be utilized by patients as well as clinicians. This will eliminate the need to do a separate one and a separate resource listing. And you can even highlight in your overall resource listing, these are the things that are especially helpful to cancer patients, or to tie it to certain service lines. That would be a really cool thing, especially if you're doing an interactive asset map, which some of our clients are doing on their website, so that people will have the ability to click, you can go to the website and click on this. It's not just a static list. I can actually see how they come up on the map. I can actually download the list of all the food pantries in the area if that's what I'm looking for. It's kind of a cool thing. You also want to look at the fact that the community needs assessment from the Commission on Cancer's perspective, you've got to have you have to have the needs assessment conducted at least once within the 3-year cycle. It doesn't say it has to start the cycle. So whatever timing your overall needs assessment is, your Commission on Cancer program can line up with that as long as it's sometime within the 3-year accreditation cycle. You have to look at the needs, you have to look at potential to improve cancer to health disparities, and you have to look at gaps in resources across that continuum. So that little map that I mentioned to you earlier being really helpful can help you look at what resources do you have versus what the community has, and are there any gaps from what would be that ideal model. The results of the community needs assessment can serve as the building blocks for the program and the evaluation. The Cancer Committee may delegate the responsibility to a specific individual, subcommittee, or department. Well, geez, let's let the Community Health Needs Assessment group, who's already doing it, be the folks that do it for the Cancer Committee, so that delegation can happen. And as long as the results are documented in the Cancer Committee minutes, so somebody who has the overall needs assessment results as well as the cancer-specific outcomes of the process need to go to the meeting and present the data, so it can be documented in minutes. They also have to select which tools. So the Commission on Cancer doesn't prescribe, oh, we need to have this many focus groups or this survey or these interviews. It doesn't prescribe that. It just says it has to be there. But the report, the evaluation reports have to have health disparities, the navigation process, the population served and barriers, activities and metrics, and areas for enhancement. So that's the evaluation report that needs that. They really don't prescribe the specifics of what has to go in the needs assessment as long as one is done and it's documented. The third thing you want to do is recognize that the outreach and barrier elimination process should be counted as a community benefit and included as an intervention strategy or an implementation strategy. And appropriately implemented outcome and impact measures could also achieve significant cost savings and quality of life improvements if they're tracked and reported. And I'll talk about a couple of examples of those in a few minutes because I'm going to talk a little bit about the evaluation process. Because many hospitals, I've found, do program evaluation, except they do it intuitively and they don't necessarily document the results of it. So from the Cancer Committee's perspective, you want to engage the stakeholders, you want to describe the program, you want to focus the evaluation design, gather credible elements, justify the conclusions, and ensure use and lessons learned, and that it's documented in the minutes. Now, how do you describe your cancer program? I'm recommending to you that you actually create a logic model for your cancer program so that you can see the inputs, the activities, the outputs, the short and medium and long-term outcomes that need to be part of your program or should be part of your program. Now, if your organization is accredited by the Commission on Cancer, if you look at the intermediate term outcomes on this example logic model, there are specific treatment protocols, and I think I even have a slide. My next slide might even have the treatment protocols on it from the Commission on Cancer. Those are part of your intermediate outcomes. You're already reporting those, okay? But you also want to look at making sure that some of your short-term outcomes are actually measured as a result of your screening activities. And one of the things that one of our clients actually did was they created a way for the nurse navigator, as they were going out doing outreach and screening activities, to actually log the people into the information system during the screening activity instead of waiting for them to come into a procedure. This allowed the hospital to actually start to follow up on these people and say, of the 50 people that were screened, how many of those actually showed up for a mammogram? Did they come with a voucher to get a free mammogram? So you want to make sure that you're able to do that. Look at the number of people that are diagnosed with cancer at each stage. And One of the things that you want to watch for, and I mentioned earlier about we could really watch the cost savings of these things. If you're working on a defined population, such as a housing project or a particular population, a subpopulation of the community, you could be looking at, if I work I'm doing screening activities every year with these people, am I finding, in year one, a number of people in stage 3 and 4 breast cancer, whereas in year 2 or 3 or 4, I'm seeing less people in stage 3 or 4, but I'm seeing people in maybe stage 1 or stage 0. You can actually quantify the impact of the people that are being diagnosed at earlier stages by the cost avoidance, by watching the cost associated with the people who show up with stage 3 and 4 cancer, because the resources involved for caring with those people are going to be quite significant. I also circled here the number and percentage of patients that decreased in patient distress or psychosocial distress. One of the Cancer Committee requirements is that cancer patients are screened for psychosocial distress. And one of our clients actually discovered, as we were talking about this and looking at their short and medium and long-term outcomes, that they actually used an assessment tool to determine if they had psychosocial distress and were going to be referred to the navigator for additional assistance or to other services. But they never really looked at and measured psychosocial distress at the end of the cancer treatment to see if that changed at all. And because, ideally the navigation program for sure should, and the resources that we're providing to the patients should help their quality of life improve and their psychosocial distress decrease, but yet they weren't measuring it. So they actually changed their process so that at the last treatment, when they knew it was going to be the last treatment for a patient, they actually replicated that psychosocial distress tool so that they would be able to have a pre and post measure of that distress indicator. So that's kind of an interesting thing to look at. So you want to lay out your logic model so that you see your activities and your outcomes. I just put this in here. These are the treatment protocols that probably somebody somewhere is measuring in your hospital already. But they are things that need to be measured. And you could look at these treatment protocols and the percentage of people who are actually administering them in relationship to the psychosocial distress and to the other things, the other barriers that the navigators are seeing in their outreach. So here's a very quick suggested evaluation process that organizations can use by convening the Cancer Committee, reviewing the quarterly report or at least the annual data. And for the Cancer Committee requirements, it has to be semi-annually. Determine what's not working and refine the plans, and then do a collaborative impact reporting process. I also included for you a timeline of how an evaluation process might look like at the end of a fiscal year, if you're interested in a timeline to do that. And then the last piece of advice is automate the key metrics associated with the cancer program as part of the electronic medical record. And if your outcomes are not automated, what you want to do is really start to talk to your IT friends. Ask yourself the question, does the outcomes data for all the logic model items already exist somewhere in the EMR? Because what we found is sometimes the data is there. We just don't have a report written to get the data out of the medical record. And in some cases, we've got records in multiple systems. Somebody in the information systems department has to create a crosswalk across 3 different softwares to be able to create a report to get it. But it can be done if you have the right person actually working on it. And if the data doesn't already exist, you want to ask the question, how can we create a process to capture it and report it? And I'm not getting into a lot of detail in this particular session on how to automate those indicators. I'm actually doing a webinar for ACHI that's going to be the second or third week of November that is dedicated to the whole IT is your friend process and how do you automate those outcomes indicators. I'm also going to do a little commercial. I'm doing a half-day workshop for the ACHI conference in March in Baltimore on automating indicators and how to break some of these things down into the right fields into medical records, and kind of doing a workshop format to help people actually make some progress on this if they're really struggling with it, and they're coming to the ACHI conference. So in conclusion, what are the key takeaways and things to remember? First of all, envision your cancer program as a key population health initiative driven by community needs. The needs assessment process to meet both the IRS and the Commission on Cancer requirements and include the cancer program as an implementation strategy in your overall needs assessment. Connect the dots on that. You're already doing most of this stuff anyway. You ought to do a little bit less of it and not have duplicative work. Describe your cancer program activities, expected outcomes, and impacts through a logic model. That will help you look at all of the different things you want to have as outcomes and say, do I need to go back and change anything in how my program works to get the outcome that I need? And then lastly, you want to try to automate the data reporting of the outcomes and the impact through the Cancer Committee, Community Benefit, and 990 reporting processes. You want to do one effort that gets reported in 3 places, because you don't have to do it 3 times, you don't have to do it 3 ways, you only have to do it once. And if you want some additional help on that, Kathy from my office is telling me that ACHI webinar is on November 18th at 2 p.m. Eastern Standard Time. So you can put that on your calendar and show up for that if you're interested in more information. And this was a pretty short one today, just a little connect the dots. So with that, I'll stop and ask, are there any questions from anyone? And I will unmute my line.
The conference has been unmuted.
Do you have any questions? Hearing no questions.
Deb?
Yes.
No?
Yes.
I do have a question.
Okay, good.
Community benefits mostly is focused on the medically underserved population.
Correct.
Disparities. So is this same issue applies to the cancer accreditation process?
Absolutely. Absolutely. And
so it has to be honing on the disparities aspect, or is it broader? Because, the cancer center targets everybody that needs the services.
Right. I think it's both, okay? Because if you think about your overall community health needs assessment, most of us that do needs assessments, we have to, as part of the IRS requirements, look at, are there any medically underserved? What are those special populations? Are there, do they have access to care? Are they being, do they have appropriate opportunities for screening and wellness, et cetera? The Commission on Cancer requirements go a slight step further and say, not only do we want you to recognize what those disparities and those barriers to access might be, we expect you to focus on eliminating those barriers and doing outreach to those underserved populations or anywhere there might be a health disparity, so that you are looking for those people who might have cancer and get them into your program before they're at stage 4 and they're a train wreck. Okay? So those are community benefit activities that most of your programs are doing anyway. And my big concern is that we have cancer programs out there that are doing their own needs assessments when we could easily just take our overall community health needs assessment and do a little bit of, sort of tweak it a little bit to make sure that we do focus groups with cancer patients and people who are at risk for cancer, and we look at the barriers to care, not just. And it really isn't just for cancer, but it could be for anything. But the Commission on Cancer requires that, well, I'll call it that extra level of care. But on the flip side of it, if you're a community benefit administrator and you've got a cancer program and your cancer program isn't reporting all of the community benefit around those outreach and screening activities, especially among those underserved populations or populations with disparities, you probably ought to be reporting it because you're doing it.
Okay, thanks.
Okay? But again, most of us, especially in very large health systems, we work in our own departments and we do our own stuff, and we don't always connect the dots. We don't always connect the dots completely across the continuum of care. And I'm suggesting now that we not only connect the dots across the continuum of care, we connect the dots with the planning process and with the needs assessment process so that we're doing things once and reporting the outcomes of it in multiple places instead of doing things 2 or 3 times in different departments, in different ways.
Okay. Thanks.
You're welcome. Any other questions? You can feel free. I'm going to stop the recording. And thank you all for joining today. And if you do have any other questions, you can feel free to contact. You can stay on the line for a few minutes if you'd just like to talk to me, or you can feel free to email or call us. We will be sending copies of this presentation to anyone who signed up, but you can always feel free to drop us a line or give us a call if you have any other questions after the presentation today. Thank you all, and have a wonderful rest of the day.
Thank you.
Thank you.
Thanks, Deb.
Thank you. Hey,
Yes.
you're the only one that's left.
I don't have any questions, though.